Thank you, Sue, for that. So yeah, I'm going to talk about does fit into the postnatal care, and this is the bit of postnatal care that sometimes as midwives we perhaps forget or we leave off the list. Because we feel maybe it's not appropriate to talk about contraception so early on after birth. So I'm just going to go through a little kind of just a little overview of what postnatal contraception is and the importance of it. So when we talk about post-pregnancy contraception, we are looking at any contraceptive methods which are in the early postnatal period. So this is the including straight after childbirth, or if after abortion, ectopic pregnancies, or any pregnancy really, or miscarriage, or any gestational trophoblastic disease as well. And it is written into the women's health plans in the UK. It's really explicit in each women's health plan, and this is in all the four countries of the UK. It's really explicit that postnatal contraception should be part of maternity care. And it says in the NMC, in the standards of proficiency as well, that actually we should be, as midwives, providing key information around around family planning and postnatal contraception. And recently, the College of Sexual and Reproductive Health, this used to be called the Faculty of Reproductive Sexual and Reproductive Health, has now changed their name to the college. They have just, hot off the press, they have released a document called, which is a guide for best practice around post-pregnancy contraception. So actually, it's really detailed. So I would kind of encourage you to read this. I think it was just released last week, so they're good documents to read. So just some kind of background, really. So we know in the UK, around 45% of pregnancies are unplanned or ambivalent. And we know that fertility returns within 21 days of birth. So actually, when we're saying go and see your GP at 6 weeks, actually it's too late. We want to kind of get provision on board prior to that 21 days, really. And we know that 1 in 8 Paris women conceive and continue with another pregnancy within a year of a previous birth. So actually, that's quite stark number. And almost half of women resumed some form of sexual activity within 8 weeks of birth. Even though, immediately following birth, they'll say it's the last thing on their mind. They really, it's the last thing they want to do is be thinking about intercourse. But actually, when they start to recover and their bodies start to feel back to normal again, they actually that time goes really quickly. And we also know that almost 1 in 13 women presenting for an abortion or delivery had conceived within a year of a previous birth as well. So that the numbers are there, and actually, so that it does realise that it is a really important topic. Also, miscarriage is the most adverse pregnancy outcome. So in the UK, in about 10 to 15% of all pregnancies result in a miscarriage. And that was really, that was a lot higher than I actually thought. So this was from the best practice guide. So that was really interesting to hear that. And we know about a fifth of women are unable to access their preferred method of postnatal contraception as well. So, we might be discussing it, but it might not always be available for them. And because it's the NHS, we have to talk about money because we have no money. But actually, this is a spend to save this service. So providing contraceptive service in maternity settings has estimated savings of £32 for every £1 that's invested. So it is a spend to save. It will help kind of save money in the future. So when it's really important that we talk about pregnancy spacing, and again, as midwives, we don't tend to talk about the importance of pregnancy spacing and why it is important. So the World Health Organization recommend birth spacing of at least about 24 months before planning the next pregnancy. And studies have reported that interpregnancy intervals of more than 12 months may reduce maternal risks of anemia, third trimester bleeding, premature rupture of membranes, maternal mortality and morbidity. And within this, what they found is that actually it can reduce the risks of preterm birth, low birth weight babies, small for gestational age, and infant mortality in subsequent pregnancies. So it is a public health issue. And we also, and there's other reports that support this as well. So the methods that are available then. So in the early postnatal period, so before that 21 days, we do recommend if you're going for pharmacological methods, we recommend the progestogen methods. So progesterone-only pill, the progesterone-only injectable, then the longer-acting methods, so the longer-acting reversible contraception methods are known as LARCs, and this is your subdermal implant, which looks like I'm not allowed to call it a rod, but it is, which is subdermally, just under the skin in the arm, and that releases progesterone throughout the body, and it releases it for over a 3-year period. So it's a really good method of contraception. The other long-acting reversible method of contraception is your intrauterine systems, or your coil, So your device, so your system is your Mirena coil. So this is with hormone in it, so with progesterone in it. And then the other one is a copper, which is it's not got a hormone in it. The progesterone can last for Mirena coil can last for up to 5 years. The copper one can last for up to 10 years. So really good methods of contraception. One that we don't really talk about very often, but actually is a really good method, is your lactational amenorrhea method. So this is reliant on 3 things. This is relying on the periods not starting again, baby being under 6 months of age, and exclusively breastfeeding. So this is what's known as your natural spacer, your natural birth spacer. And what we do as midwives, we tend not to rely on this because, or we say to women, sorry, just my light's flickering here a second. We say to women, oh, it's not reliable, but actually it is really reliable as long as those 3 things are in place. And I think that's really important to say to women, this is a really reliable method of contraception as long as those 3 things are there. So I'm just going to jump over to a table, which I thought might be quite interesting. And this is a table from Trussell. It's quite an old table now, but actually it's still very relevant. And this is the actual, if a woman didn't use a method of contraception, there is an pregnancy occurring within a year. If they use fertility awareness methods and they use it well, that could actually be 1 to 9% chance of a pregnancy. But if they use a lactational amenorrhea and they use it as perfect use, there is a 0.5% chance of a pregnancy. So you can just highlight how reliable it is if it's used properly, like anything really. If you use it, you can, for example, the oral contraceptive pill, it is reliant on you taking your pills, and actually that could fail if you miss a pill. So if you use it typically, it could be about a 9% failure rate, but actually if there's a perfect use, it's 0.3%. So you can see, you can have a little look at this table, and it's really interesting to see the methods that are really reliable. And the most reliable method would probably be the implant, the subdermal implant. So it's great. It would be great to have a service where midwives are fitting subdermal implants prior to discharge home from hospital or in the community following the birth of their babies if they've had home births. So it's a skill that midwives can have. So we set up a postnatal contraceptive service back in 2016 in Cardiff, and we had a drive to train midwives in the different methods that are available, and all of the eligibility criteria around this, and actually so they could provide that really key information to women to make that choice. But what we found is we don't want to have that first conversation with women about contraception as soon as they've given birth. It is the most inappropriate time. Women they're tired. They don't want to be thinking about contraceptive and especially your long-acting methods. It seems such a committal thing to do. Committing to that long-acting method immediately after you've given birth is actually something that you need to have time to consider, talk it through with the partner. It's really important. So we discussed this in the antenatal period, and this is key, is that planning in the antenatal period, and this is key for any postnatal care really, it should be planned and individualized in the antenatal period, ready for the postnatal period to start. And so we usually have a discussion around about 16 to 18 weeks, which seems really early, but actually it works. What we're doing is providing written information about contraceptive methods. And then we'll revisit it at 34 to 36 weeks with the birth planning conversation. So we'll revisit methods of contraception. And then if they choose to have a subdermal implant, we do have midwives trained in the unit that can do that prior to discharge home. Or if they wanted to perhaps wait just a couple of weeks, that's fine. We can do a fast track referral to our sexual health department as well. So we've got a really good pathway in place. If they did want the intrauterine coil immediately following birth. This is something that we did try and embed into our unit. We're not quite there yet. It's and the plan is for placenta out, coil in. So it's kind of a really good method of a great time to actually insert a coil is when you've just given birth and actually you've got good pain relief on board. You can pop it in before you suture. So it's something what we're trying to do is in the future is to get midwives trained to do this, because what better place to kind of have it done when you're already there and perhaps you need a couple of sutures put in. You can just actually pop a coil in quickly. So it's really, and the RCOG have produced a lot of resources and information around post-placental intrauterine device insertion. So that's our future plans really for this service. But at the moment, we are actually offering it at caesarean section that we can actually pop a coil in there as well if that's what they would like. But again, we need that planning in the antenatal period in order for this to happen postnatally in a timely fashion, and actually that it's not making a decision on the spot. So we started this service back in 2016. So then we thought, actually, is it working? We're offering women contraception. Are they going home with it? Is it working? So we wanted to have a look at what proportion and what is the overall rate of uptake of postnatal contraception, and then we wanted to kind of link it into socioeconomic, lifestyle, pregnancy, birth characteristics, just to see if that made a difference to their decision. Let me move my slide. So we pulled 26,081 records over a 5-year period. So we put some variables into our maternity informatics system back in 2018, and we wanted to know women that had a discussion about contraception and the methods that they had chosen. And what we found was actually 91% of women were having a discussion around contraception prior to discharge home. So we couldn't capture if this was done in the antenatal period or the postnatal period, but actually what we found is that midwives were having that discussion. Then only 13% actually went home with a method. So we thought that was really interesting. So there's this huge gap between discussion and uptake. And the majority didn't want any discussion or didn't have contraception. That's whether they declined it or whether it was just not available for them. And then this graph kind of highlights this really. So this is what we found in this graph is that actually over time, midwives, once we'd had this drive it was during kind of COVID, we had a big drive, but we wanted a drive to increase the discussion around contraception. So we did that, and we noticed the levels went up, the discussion was there. But these lines here are the methods. And as you can see, the methods is still that huge gap. So now we want to know is actually why women, perhaps if they're having that discussion, why maybe are they not going home with it, or why are they choosing not to have it? So it's fascinating stuff. We put the COVID pandemic line in here because actually we thought this was really, really interesting. As you can see, there was a big spike. There was a big spike just after COVID around the discussions that kind of really went up at that point. And this is because community services had ceased, that people couldn't get to their GPs. So actually we were offering 6 months of the pill to go home with. So they see a big spike in the pill being taken, and then also the discussions going up as well. So it was really interesting to find that. Outcomes in relation to social demographics and to birth outcomes. This is just a forest plot which highlights this. So the side on the left-hand side, these are the women that are less likely to receive postnatal contraception. And then on the right side, these are the women that are more likely to receive it. And what we found was that the women who were unemployed, single, that they were maybe didn't have a labour, so your elective caesarean sections or caesarean birth were more likely to receive contraception. And also if they were artificially feeding their baby, but women that were breastfeeding were less likely to receive contraception. So we kind of wanted to explore this a little bit more. This data then has informed the next stage of the study, which is looking at asking women why, asking midwives and doctors why and their experiences of postnatal contraception. Kind of just highlighted in just a more easier way to see, really. So we saw there was a higher contraceptive intake uptake with cesarean birth, with greater deprivation, with a younger age, artificially feeding, and with a higher BMI, which actually goes against what we see in practice, with that women sometimes decline contraceptive methods because they feel that they're gonna gain weight. But it was interesting to see that actually the women with the higher BMI actually did choose methods. And then we have a lower contraceptive uptake with women that were married, that were older, and that they were breastfeeding or Asian and mixed ethnicity as well. So in summary then, the key inequities that we identified was that less affluent women were more likely to receive contraception, and then uptake declines with affluence as well. Less likely to receive contraception. Unemployed and single mothers have a higher uptake than employed and married mothers. And this could be, when we kind of delved into this data a little bit, delved into the research a little bit more, we tend to focus on the more vulnerable women. We focus on the women that are in the lower deprivation, and we tend to ignore the women that are married and employed, and it's that perception that they are educated and they know exactly what method they want, but actually they're almost forgotten about. And postnatal contraception should be for everybody. It shouldn't just be targeted. It should be for everybody. Should have the same offer and the same information given. We also said that we thought that cesarean section is linked to a higher uptake, especially the coils, and that was stark in that data. That's because it's on our pathway, we're offering at cesarean section, and that breastfeeding mothers were less likely to receive contraception. So then we thought, let's ask women. So we put a survey out. We surveyed 150 women, and we did some online interviews with 6 women. And then we held 2 focus groups for women where English is not their first language, and that they are navigating a maternity system that is different to their birth country. So we wanted to understand perspectives for everybody. And what they found is that actually respondents said that contraception was discussed with them in pregnancy. So we thought that was great, lovely, that it's being discussed. And they stated that the most suitable time to commence a contraceptive method was at 6 weeks. So that's what they found, is that actually they told us they would prefer to have, they feel the most suitable time would be over 6 weeks. The respondents stated that the most suitable time to start was immediately following birth, but actually more of them felt it was at 6 weeks, but only 25% of them felt that it was useful to have immediately following birth. And 69% were offered contraception following birth, with respondents either clearly declining or choosing not to initiate contraception at that time. So that was really interesting. So when asked for the reasons behind why maybe they didn't want to start it so early, they expressed concerns about using hormonal contraception and said that in the early postnatal period, and stated that they wanted to allow their body to recover from birth before commencing the period, before commencing the method. And again, this comes back down to that the myths around the safety of it in the early postnatal period, especially if they're breastfeeding. Some respondents explicitly stated that they were waiting again for recovery. And some stated that their preference for non-hormonal contraception was there, and they felt it would be safer to use non-hormonal methods in the early postnatal period. And then some respondents actually cited anxiety around their mental health when they're using hormonal contraception, and that actually in the early postnatal period it is a vulnerable time when they are experiencing different changes in hormones, and they were worried that their mental health would be impacted if they started hormonal contraception at this time. And then others had said that they had some negative experiences with around emotional well-being when they were using hormonal methods as well. Others said that they wanted to delay starting it because they felt that they had good provision with lactational amenorrhea, and that was really good to hear that there were some respondents that were relying on this method. And others said that they were not planning to resume any sexual activity anytime soon as their reasons for not starting, which is fair enough. So then we asked the doctors and we asked the midwives. We want to get a kind of really understand of all of these experiences. So we had 221 respondents for the survey for the midwives and 34 for the doctors. And we did some online interviews with 6 midwives and 7 doctors. And what they told us is that actually they felt that contraceptive discussions should be taking place in the antenatal period, and that actually, or during the community visits, not in that kind of immediately following birth. And most midwifery respondents raised concerns around the offer of postnatal contraception immediately following birth for the first time. And they stated barriers, and these are your competing priorities. And we know that and this is what when Sue mentioned about postnatal care being the Cinderella of the services. And there is a lot to discuss in the postnatal period, in the early postnatal period. There's a lot of clinical priorities, and they're all competing. They're all just as important. So actually, midwives felt that is this the most appropriate time to discuss it? And also the perception that new mothers do not want to engage in this discussion, and they may have that overload of information in that postnatal period. So this is why it comes back to the importance of antenatal planning. They further suggest that reduced staffing, limited time, lack of training and confidence around postnatal contraception were all additional barriers to this. And they gave some potential facilitators here, again, early antenatal discussions, and to support decision making, contraceptive training with midwifery competencies, but making sure it's culturally sensitive as well. So they didn't feel confident to discuss contraception with women that maybe they have special cultural needs and sensitivities, and actually, midwives felt that maybe they didn't know how to have that conversation. And also then your practicalities of ward stocks and getting prescriptions and PGDs and all of the things that come with that. But there was numerous comments around the importance of an MDT approach. You can't just do this with midwives alone. It has to be an approach. So using involving your pharmacies, involving sexual health, involving your obstetricians. This has to be everything centered around the women and their partners as well. And it was we wanted to improve information and education for parents with direct links to sexual health. So if they don't want to have it there at the time, then we can signpost them to the relevant people. And then there was obviously the time pressures and the lack of knowledge, but also the funding and commissioning services. So having the funding and commissioners really behind this and having this written into Women's Health Plan will push this forward. So again, in summary, we found that it was lack of trained staff for subdermal implants and PPIUC. So this is the postpartum, the post-placental intrauterine devices insertion, and there was lack of trained staff on that. So there was a call to increase the staff training, increase the midwifery training for subdermal implants. Then it's the myths and misconceptions. So it's that kind of perceived that women don't want it in the early. But also, is it because they're scared? Is it the safety around? Are they scared that actually they feel it's not safe for them to take? So it's myth busting that we need to look at, and especially with breastfeeding, the progesterone only methods are very safe in breastfeeding. And then also the cultural beliefs as well. Then we've got the competing priorities of the busy postnatal ward, the busy postnatal care midwife, trying to kind of do her very best, his or her very best in providing postnatal care. And then sometimes these physical recovery trumps the kind of contraception then. So we're more focused on the kind of priorities of physical recovery than we are on the actual methods of contraception. And then provider bias as well. So age, marital status, employment status, that actually, we're talking about that forgotten cohort of women that don't get offered the contraception because they're perceived to know it all, and they don't. So the best practice would then be supportive leadership on this, so kind of really driven, but driven from kind of your governments as well, and having midwife or nurse champions available just to kind of have somebody there who's driving this forward, but it being a multidisciplinary working group as well, and it being led by the woman. This is really important. The women has to be at the core of all of this decision making, having access to midwives having access to training and education around this, and that there is evidence, that there is access to evidence that is culturally appropriate, and that they're in the right languages, that women can really make that true informed consent in the antenatal period. And I'm going to stop talking there. Thank you very much. I'm going to stop sharing my screen.